For the skills fair checkoff this year, we decided to add C-sections to our skills checkoffs. My understanding is that if we are going to get a C-section in the main ORs, it'll be under one of two circumstances. The first being there are 3 C-sections going simultaneously over at women's, and there's a need for the 4th. The other scenario would be a trauma that required an emergency C-section, and the level of the trauma being one that needed to happen in our main ORs and required the skill set that we have in the main ORs. So while this is probably a fairly unusual situation, it has happened since women's moved here. It happened before women's moved here, and it will likely happen again. So I'm just going to cover what we need to know, the main details, and focus a little bit on how C-sections are typically done the Moses Cone way. First, I want to look at the typical steps for a scheduled C-section. This is a nice, calm event. Everybody has planned on being here at a certain set time, and while it's likely not what we're going to see in our ORs, it's going to be a nice foundation for the situations that we would encounter. So the patient would be brought to the OR. They'll be positioned on the side of the bed for spinal placement. We will attach all of our monitors, get our first blood pressure cuff reading. The spinal will be administered by the anesthesiologist. Typically, they use 0.75% bupivacaine. The CRNA is responsible for drawing up the narcotics, 15 micrograms of fentanyl, which is 0.3 mLs, and 150 micrograms of Duramorph, 0.3 mLs, in a TB syringe most often. And you will add this to the anesthesiologist's spinal dose. For a C-section, we need a surgical block at T4, which is approximately the nipple line, and we do not allow the surgeon to start until we have tested the spinal and made sure that we have an adequate level of block. You'll get one. I would love an 18 gauge IV. I think at women's they typically work with a 20 gauge IV, which is fine. ANSEF will be given just like in our ORs. If the patient is greater than 120 kilograms, you'll use 3 grams. If they're allergic to ANSEF, discuss with the surgeon what alternative antibiotic prophylaxis is needed. We typically give Zofran as soon as the patient gets in the room and often start the neo infusion between 40 and 60 mics per minute as the spinal is being administered or right before the spinal is being administered, with the goal of avoiding the hypotension, which we all know leads to nausea and vomiting and is great for all parties involved if we can avoid it altogether. Positioning will be supine with a slight left uterine tilt. Arms will be out. Currently, pharmacy is mixing 30 units of Pitocin in 500 ml bags. This is different at every facility, but at Cone, this is what we're using at the moment. So discuss with the surgeon when to start it. The baby will be out and the umbilical cord will be clamped. And we'll give roughly 300 mLs in the OR is what the women's CRNA said they typically do. Give or take, every patient's going to be different. And the remaining 200 mLs will be infused on an IV pump in the recovery room. Expected EBLs between 500 and 1,000 mLs, and other pain control options postoperatively are Toradol if the platelet count is greater than 150,000, and Tylenol, but as usual, discuss with your surgical team before giving these doses just to make sure that they're a good option for the patient. For an emergency C-section, ideally we would have time for aspiration prophylaxis. This does not always happen, but if you do have a few extra seconds, Bicitra 30 mLs or Pepcid IV are both very good options just to prevent risk with aspiration. In the event that a uterine rupture has occurred, they will add azithromycin to be given after the ANSEF dose. I was told by our women's CRNAs that this should be given very slowly because it will also cause your patient to have extreme nausea and potentially vomiting. So they give it over an hour after the ANSEF has been administered. Emergency C-sections can be done as a general anesthetic or as an epidural. If the epidural is already in place, it can be dosed for surgical coverage. So if it's a general anesthetic, we want to make sure that we wait to induce until the surgeon is gowned, gloved, and in the room. The belly will already be prepped. The patient will have been pre-oxygenated during this preparatory time, and when the surgeon is ready to go, we will proceed with an RSI. Use your glide scope, not the time to be a hero, just secure the airway and get it done. We will hold fentanyl and Versed until the baby is out. The skin incision will be made once the endotracheal tube is through the vocal cord, so make sure you inform the surgeon that the airway is secured. They'll make incision while you're taping the tube. Indications for a general anesthetic would be severe fetal distress, just to keep mom and everybody else in the room calm. That's a real reason. a coagulation disorder that prevents us from doing a spinal or a epidural, and also if the epidural is not working, we would proceed with a general. If you have a few extra minutes and the epidural is already in place, we can convert a labor epidural to cervical coverage. And to do this, we have to increase the block from a T10 level, which is closer to the nipple line, or sorry, T10 is closer to the umbilicus, and we need a T4 block up at the nipple line. This is increased with 2% lidocaine with epi in 5 ml increments. Wait several minutes between each dose, reassess, and give 5 more. I've heard between 10 and 20 mLs is typically more than enough to get a sufficient level of the block. Once the baby is out, 3 milligrams of Duramorph can be added to the epidural for additional pain coverage over the next 12 to 24 hours. You can also add 1 ml of sodium bicarb to 9 mLs of lidocaine to speed the onset. The women's CRNAs said they typically don't do this very often anymore. If your epidural is spotty or isn't working well and the C-section is in progress, you can try using ketamine and Precedex to bridge the patient. Chlorprocaine can also be handed over the surgical field. They can dump it directly into the uterine cavity to try to provide some additional coverage. And if you're simply not making it, of course, you can always go off to sleep. A review of the pharmacologic uterotonic agents that we do not use very often on a regular basis includes Methergin, Hemabate, and Pitocin. These are the 3 you're going to see most often, and you'll see Pitocin with every C-section. So starting with Methergin, you're going to give 0.2 milligrams IM, usually in the deltoid. It's the easiest to get to. We store this in Corpixis A. Onset 2 to 5 minutes, duration 3 to 4 hours. Major consideration with Methergin would be patients who already are hypertensive. You can see an exaggerated blood pressure response with administration of Methergin, and we would want to be cautious in our patients also who have preeclampsia and are just prone to hypertension at baseline. You can also see some nausea, vomiting, and rarely an MI. Hemabate is refrigerated, also in Corpixis A. The dose is 250 micrograms, also given IM. You can repeat the dose, but not to exceed 2 milligrams total. Consideration for Hemabate, the big one is caution with asthmatic patients. It can cause bronchoconstriction. You also want to be cautious with hepatic and cardiovascular disease. Pitocin, we kind of talked about already. Currently, pharmacy provides 30 units in a 500 ml bag. In our OB emergency drug box, which we'll talk about, we have vials of 10 units per ml, so you can make your own bag or additional bags as needed. Onset is rapid, duration 3 to 5 hours. Considerations are headache, nausea, vomiting, and rapid infusion will cause tachycardia and hypotension. We see that a lot, especially if they're having trouble with a boggy uterus, so just be aware that that is a complication. Less commonly used agents include Cytotec. This is usually administered by the surgeon directly into the myometrium. It can also be given rectally, vaginally, or a buccal route. The only one that we're going to deal with would be the buccal route. Considerations for Cytotec are that it doesn't appear to exacerbate bronchoconstriction, so it could be a good option for your asthmatic patient, but it can cause diarrhea, shivering, pyrexia, and headaches. Less commonly used by far medications, but might be good for a trauma, especially as TXA. IV. Dinoprostone came up, but the CRNAs over at Women say they have never given that. And Factor VII is a good, safe option for our trauma patients as well. Special considerations for a trauma section. Of course, in this event, you're going to want 2 large bore IVs, a type and screen, blood available in the room. You will utilize your massive transfusion protocol as needed, including cryo. I would be cautious with crystalloid fluid overload in these patients. 24 hours postpartum is the highest risk period for mom because the blood volume that's increased all throughout pregnancy does some major shifting, and it can be really high risk for CHF exacerbation. So if it were me, I would probably try to limit my crystalloid and go to product sooner than later. Hopefully baby's going to be out within the first 2 minutes. So other than that, once baby's out, you guys know how to do a trauma. I don't think it's very different. You want to get baby out, stabilize mom, take deep breaths, and just do what you do on a regular basis. One thing I do want to talk about is if you have a patient coming in for a D&C or a D&E, which we're seeing a lot of these recently, if the mom is Rh negative and they have not received RhoGAM in the last 12 weeks, they will require what we call an Rh-Ig workup. If they are less than 20 weeks gestation, short stay should order the Rh-Ig workup. If they're greater than 20 weeks, PACU should order the Rh-Ig workup within 1 hour after surgery. So while this is not an order that we're directly responsible for putting in, it is something that we all need to be aware of from a safety standpoint, especially since we don't see these patients every day and we have a lot of new staff. So I just wanted to go over that again. Lastly, we do have an emergency OB drug box. This is kept in the anesthesia workroom, right up where the MH supplies are to the right of the pharmacy window. I opened it up so you guys could see what's inside. There's chloroprocaine. There are 4 vials of Pitocin. There is lidocaine with epi. There's nitroglycerin spray, which can be given if they're having trouble getting, if the uterus is too tight and they're having trouble getting the baby out. It can help relax the uterus. Several doses of bupivacaine, a scope patch, and in the bottom section there's 1 bag of the Pitocin that we had discussed. So if you have a C-section, you can grab this box and take it back with you. And I'm far from the expert on C-sections. There are several CRNAs who do C-sections here at other facilities that would be great resources if you guys have questions. If you do have any questions, feel free to ask me and I'll try to help you find out the answer. Thanks for listening.